Thank you, Lynn. For those of you who don't know, Lynn is the man. He is the person who works so hard. He and the rest of the staff, the team, they work so hard to bring us this wonderful conference all year round. Can we give them a round of applause? And Lynn, let me tell you, it wasn't snowing in Cleveland where I came from, but it was cold. And I'm happy to be here in the warm weather. And it's so great to see all of you here. And as Lynn said, my name is Marlene Harris-Taylor. I'm a reporter producer at the PBS NPR affiliate in Cleveland, Ohio. I focus on health issues. We have a 3-person health unit there. And I'm the newest board member. And I bring you greetings on behalf of the entire board of directors and our president, Ivan Oransky, who's down front here. And I'm so happy to have the honor of introducing the speaker for our kickoff event here in Phoenix. His name is Dr. Donald Warne. He is professor and chair of the Department of Public Health at North Dakota State University. As a member of the Lakota tribe of South Dakota, he comes from a long line of traditional healers and medicine men. The Stanford and Harvard-trained physician and researcher has done extensive examination of health disparities in First Nation populations in the United States. Through his focus on the health of American Indians, he's been able to highlight and bring greater attention to health disparities unique to this particular group. He also has a deep grasp of how the history of racism and genocide in the U.S. toward Native peoples is still contributing to their health outcomes today. After having an opportunity to chat with him this morning, I can also tell you that not only does he care about his people, he's also a loving steward of the elders in his family, providing a watchful eye over their care. So please help me in welcoming Dr. Donald Warne to AHCJ 2018.
Hello, thank you and welcome to all my relations here today. Again, my name is Dr. Donald Warne, and I'm Oglala Lakota, originally from a small town called Kyle, South Dakota, on the Pine Ridge Indian Reservation. And I always like to ask, how many people have been to Kyle, South Dakota? One. That's one more than usual. That's actually pretty impressive. You'll have to tell me later how it is that you... Oh, very good. Eagle Butte as well, another small community in South Dakota. So I do come from a long line of traditional healers and medicine men. My Lakota name is Prejuta Wichasha, which means medicine man in Lakota. I was named after my grandfather. His, English name would be Louis Stabber. We're a descendant of Chief Stabber, who was a well-known leader in South Dakota in the late 1800s. But I was given his Lakota name in a traditional ceremony many years ago. And I like how our names are very descriptive. You know, there's meaning behind it, like Prejuta Wichasha means medicine man. And I used to joke, people would ask me, what does Prejuta Wichasha mean? I say it's Lakota for Steve. No, I'm just kidding. Yeah. Well, I'm very happy to talk about our issues here in this setting, and I really appreciate the planners for including Indigenous issues. And it's important, especially thinking about where we are here in Arizona. A lot of people don't realize over 28% of the land base in Arizona is actually reservation land. So more than a quarter of the land base is tribal land in this state. And there are 22 tribes, each are sovereign nations. And of course, I'm from the Dakotas originally, but I worked here for a long time. I even did my undergraduate training here at Arizona State University. And I was the health policy research director for Intertribal Council of Arizona for a number of years. So deep roots here, and I really thank the local communities and local tribes for welcoming us to the beautiful state of Arizona. Well, again, I'm originally from Kyle, South Dakota, on the Pine Ridge Reservation. And the traditional name for Kyle is Prejuta Haka, which means medicine root. And from this area, we have a lot of our traditional healers who are from this region historically, but also in modern times. And we still harvest a lot of our traditional medicinal roots and herbs from this region. So in many ways, Kyle is an impoverished community when we look at financial issues and educational status and those other measures for social determinants of health. But it's very rich culturally. So I was very fortunate to be able to be connected to traditional culture while I was growing up. One of our big challenges is educational inequity. This is a picture of Little Wound School in Carlisle, South Dakota, and it's kindergarten through high school. And one of our big challenges is that less than half of the children who start kindergarten graduate from high school. So the dropout rate is over 50%. And that's true in many of our reservation communities. Now, does quality of education in a community correlate to health? Absolutely. And what I realized very early in my own medical career is that the issues we are facing are not going to be resolved in the hospital or in the clinic. The social determinants of health have such a much greater impact than whether or not we have enough insulin in the pharmacy, right? There's other issues when we're thinking about health and underserved populations, including income inequality and educational inequity. It's also a food desert. I'm sure many of you are familiar with that term. The closest supermarket to Carlisle, South Dakota is in Rapid City, South Dakota. That's 100 miles away. So imagine if you wanted to go to the supermarket, you had to do a 200-mile round trip to do that. So there is a cafe there called the Food Stop, and I think what they've learned here is that you can bread and deep fry just about anything and serve it for lunch. So the types of foods that are available are things that can be stored for long periods of time. So things that can be breaded, put in a freezer, then eventually put into a deep fryer. So not very healthy foods. But the other reason I like this picture, it's an action shot. You can see the res dog chasing the little girl down the street there. Right across the street from the cafe is the gas station, and the gas station doubles as a grocery store. So you can imagine the type of food that's available. So one of the terrible outcomes is less access to healthy food. And not surprisingly, we see a lot of nutritional related diseases in the community. It's a picture of one of my relatives, and you can see he has an amputation. Why does he have an amputation? Diabetes, poorly controlled diabetes. Isn't it remarkable that we all just know that now? If you had asked that question 40 years ago, people would say, oh, he must be a combat veteran, right? That must be the reason for the amputation. But diabetes has become so prevalent in many populations, and the negative outcomes, including amputations, occur so often that now we almost expect that that's going to occur. Now, in my community, there's a program that will build a ramp for people who are in wheelchairs so they can get into their home. And that's wonderful. We'll build a ramp after you've had an amputation so you can at least have access to your home. Wouldn't it make more sense if we invested in healthy food in the first place? We wait until you have an amputation, then we'll invest in your needs, but not before that. So even thinking about the food available in the schools, it's not the healthiest choices. So what's the message we're giving to our children? We're not going to invest in your health today, but after you have diabetes, it's poorly controlled, and you have an amputation, then we'll invest in your health. Same is true for things like kidney failure and for dialysis. Dialysis is one of the diagnoses that automatically makes you eligible for Medicare, right? We're not going to invest in your care now while you're healthy, but as soon as you're very sick and have diabetes complications, then we will invest. Is that intelligent? Is it ethical? I think we have to really think about our health system, and it's magnified in Indian country, but it really is a part of our entire health system. So when I have this discussion, I like to think about a brief history of medicine, a very brief history. 2000 BC, here eat this root. 1000 AD, that root is heathen, here say this prayer. 1800, that prayer is superstition, here drink this potion. 1900, that potion is snake oil, here swallow this pill. 1950, that pill is ineffective, here take this antibiotic. And year 2000, that antibiotic is artificial, here eat this root. So we've kind of come full circle, haven't we? And when we think about out-of-pocket investment in things that we call alternative medicine, people actually spend more money out of pocket on things that are considered alternatives, right? But in truth, what do we think of as alternative medicine? In many ways, it's natural medicine, it's holistic medicine, it involves ceremony, it involves energy, it involves all of these things that connect to individuals in a very deep personal way, sometimes in a very spiritual way. But we kind of have taken the spirit out of modern healthcare, haven't we? And when I think about my own medical training, the only time the word spirituality came up was when I was doing my hospice rotation. So we had to wait until there was an impending death before we even said the word spirituality. Is that logical? Is that ethical? And when we think about how people experience health, and it is in a very holistic way, we're just not very good at addressing it, unfortunately, in modern times. So when I think about public health, and I think about what we used to do from a cultural perspective, it's very different than our modern medical system. And historically, we did not have a written language. Most tribes did not have written languages. It's been translated now, so we can read and write in Lakota. But historically, we would learn about culture, we would learn about life lessons through stories. And there's a wonderful story of 3 sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister jumps in and says, this is an emergency, it's a crisis, we need to get the babies out of the water right now. And the second sister says, no, we need to teach them how to swim so they can survive while they're in the water. And the third sister keeps walking upstream. And the other 2 get angry with her and say, where are you going? Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. That's public health, right? That's working further upstream. And when I think about what we do in modern medicine, we spend a lot of time as that first sister, don't we? Managing crises, managing emergencies, managing amputations, managing heart surgery, managing all of these crises. We spend a fair amount of time on secondary prevention, right? Managing blood sugar, managing blood pressure, using medications. We spend relatively little time going upstream and finding the root causes and actually trying to address them. And that's true for the entire country, but it's even more magnified when we look at American Indian health disparities. So I know you're from all over the country, different parts of this nation. You may or may not be familiar with the IHS areas. Indian Health Service is broken down into 12 areas. And if anyone's from Alaska, I apologize. I know Alaska is not off the coast of California, but this is the best map that I have. So when you look at this map, one thing to keep in mind is that there's not a single American Indian culture or a single American Indian population. We have hundreds of tribes, hundreds of cultures, hundreds of languages. And we see a lot of regional differences in American Indian health. One of the other things that you probably notice, there's a lot of states missing, aren't there? There are 14 states that do not have federally recognized tribes. And we'll talk about why that is and how does that have an impact even on political issues. So if you come from a state in which there are no federally recognized tribes, do the elected officials care about Indian Health Service funding? Why would they? It's not part of their constituency, right? So we have challenges just by the sparse nature of our population and how we are dispersed. There's only 7 states that have at least 3% American Indian population. Alaska, Montana, North Dakota, South Dakota, here in Arizona, also New Mexico, and Oklahoma. And why is that? Why is it that there's so few American Indians in other parts of the country? I think it's important to understand the historical context of why that is, that we have so few American Indians. So when I show this picture, I like to say, let's talk about Indian country. Now, we did not draw the lines between US and Canada or US and Mexico. Those lines were drawn for us. But there were American Indians throughout the entire region of what is now the United States. And there's not very many of us left in the northeastern part of this country. Is that because historically Indians just didn't like the East Coast? Too much traffic, perhaps? Actually, the 13 colonies were devastating to the northeastern tribes. And you may have heard of Amherst, Massachusetts, right? Amherst College, named after Lord Jeffrey Amherst, who was a colonial governor at that time frame. Most people don't know what he's famous for in Indian country, but Lord Jeffrey Amherst is the one who ordered the distribution of blankets from a smallpox hospital to the regional tribes with the purpose of killing them. So our first documented case of bioterrorism is our own colonial government. It was a purposeful act to completely wipe out entire populations. And they were very successful, unfortunately. So if you're interested in learning more about this, you can actually Google Amherst and smallpox, and you can even see the letters that were written back and forth between Jeffrey Amherst and, at that time, the colonial army. So I like how the word Google is now a verb, right? We can Google this information and get that data. So in the Southeast, there was a time in the early 1830s where there was the Indian Removal Act, where they removed tribal members from the Southeast to what is now Oklahoma. So in that process, many of the tribal populations were split apart. So people said, no, I want to stay in my homeland. I'm not going to be removed to Oklahoma. And some other tribal members agreed to go ahead and be removed. So that's why we have Seminoles in Florida and Seminoles in Oklahoma. We have Cherokees in North Carolina and Cherokees in Oklahoma. We have Choctaws in Mississippi, Choctaws in Oklahoma. And of the 40 or so tribes in Oklahoma, only 4 of them are actually from Oklahoma. So there's a date set aside for Oklahoma to be opened up as Indian territory. The tribal nations could move in and kind of stake their claim. So there has to be some college sports fans here. What's the mascot for University of Oklahoma? Sooners. Just by a show of hands, how many people know what a Sooner is? More than usual. That's actually impressive. There was a date set aside for tribes to move into Oklahoma. The non-Indians who got there sooner took the land. So a Sooner is a land thief. So if they were called the University of Oklahoma land thieves, it probably wouldn't engender as much school pride. But that's why every Saturday when they have a home football game, you see the Sooner schooner, right? The covered wagon going out onto the football field and celebrating Sooner culture and pride. They stole the land from American Indians. Does land ownership and possession of territory correlate to rates of poverty? Absolutely. So there are historical reasons for high rates of poverty. There are historical and policy reasons for ongoing health disparities for American Indians. The discovery of gold was horrible for the California tribes. Many of those tribes were completely wiped out as the gold rush occurred. So what we're left with in terms of American Indian population is the vast majority of us are in the West. And if colonization had occurred from the West going east, this map would be reversed. But simply because they started in the West, we have far less American Indians in the East Coast. But we're still here. We still have quite a few American Indians. Now, it's estimated that in North America and South America, there were probably about 20 million indigenous people at the time of contact, 500 years ago, about 20 million. And of that number, probably about 5 million who were here in what is now the United States. By the year 1900, that number was down to 200,000. From 5 million to 200,000. That's almost a complete genocide. Now, from many of our perspectives, this is the American Holocaust, right? It's not described in those terms, but that's exactly what it is. And it doesn't generate pride, obviously, for us as Americans, but it's a part of our history. And I talk about these things not to make anyone feel bad. That's not the intent. I talk about these things because it's the truth. And if we are ever going to get to equity, we have to walk through truth, even when it's unpleasant, right? And one of our big challenges, quite honestly, is that our issues are not well described. We're not on the front burner of anyone's media priorities, unfortunately. So many people don't know these issues. So I'm hoping we work together to find some solutions toward collaboration and at least increasing awareness of the issues. So I put a lot of time into this. You know, I used to be a primary care doctor, and I was frustrated in primary care medicine because I knew the vast majority of what I was dealing with was preventable. And we weren't going to prevent diabetes in the hospital. That's not where it's done. It has to be in the communities. So I put a lot more time thinking about historical and social determinants of health. And we did have an attempted genocide that was successful in some regions of the United States, unfortunately. And the whole idea of historical trauma, some of you may have heard of the concept historical trauma, where we have cataclysmic events in populations and then intergenerational impact from that. Another component that's unique to American Indian history is the boarding schools. Not everyone is familiar with this, but we had boarding schools where American Indian children were forcibly removed from their homes and sometimes taken thousands of miles away and put into boarding school. One of the more famous boarding schools is the Carlisle Indian School in Carlisle, Pennsylvania. The motto on the Carlisle Indian School said, "Kill the Indian, save the man." Take the culture out, of American Indian people. If you visit it, you'll still see the motto. It's on their gate. There's actually a picture of the graveyard right next to the boarding school. And every one of these boarding schools has huge graveyards. And each one of those headstones represents an American Indian child between age 6 and 12. And think about that. Thousands of miles away from home, dying alone at boarding school. Now, this is not ancient history. My own mother is a survivor of boarding schools. And she saw many of her playmates, her friends, dying at unusually high rates. Why is that? Why was there so much excess death in the boarding schools? That's never been answered. We know that there were outbreaks of things like tuberculosis, but it doesn't explain the excess high rates of death of children in these boarding schools under the care of the US government. So my question is, what about those survivors? Does it have an impact on them in terms of self-esteem, in terms of mental health, when their culture is taken away and they're watching their playmates die? That's not a healthy environment for children to live in. Now, I think that one of the scientific platforms, I'm sure many of you are familiar with epigenetics, but I believe epigenetics will be the scientific platform from which we better understand things like historical trauma. So we do see that high levels of toxic stress have an impact on gene expression. We actually modify DNA through several processes. You can methylate DNA, you can have telomere shortening, and there's other mechanisms for altering DNA based on stress. And it has been shown that these changes can be passed from one generation to the next. So there's never been an adequate epigenetic study of American Indians. So it's one of the proposals we have to NIH as we speak, is to try to get a better understanding of the epigenetics of historical trauma in tribal populations. Now, another trauma is actually food programs that are prevalent in American Indian populations. Now, WIC has improved tremendously. That's women, infants, and children. And they do promote things like breastfeeding. They're doing a good job now. But 10, 15, 20 years ago, when I was working as a primary care doctor, on reservations, the WIC programs were basically infant formula distribution centers. They were just handing out baby formula. Now think about the culture of poverty. You have a young, impoverished, new mom, and you're saying you can have this product for free. Is she going to take it and use it? So one of the outcomes of WIC is that we wound up seeing the highest rates of formula feeding in the impoverished populations. And we've proven that breastfeeding delays or prevents the onset of type 2 diabetes in children. So the population who needed breastfeeding the most was getting the most infant formula through the WIC program. So, and to think about even the name of it, formula. Does that sound appetizing to anybody? Yeah. Come on over and have a glass of formula. I mean, it's chemicals, right? Very unnatural. Now there's another food program, FDPIR. I'm sure many of you are not aware of that. That's the Commodity Food Program, but specifically the food distribution program on Indian reservations. And when I was growing up, it included things like lard, vegetable shortening, bleached flour, white sugar, white bread, canned meat, some sort of Spam-like meat product. I'm not exactly sure what that was. Grape juice, which was, I think, just sugar water with purple food coloring. Commodity cheese. I'm sure people have heard of government cheese. So when we think of traditional American Indian food, what's one of the things that comes to mind now? Fry bread. Fry bread. Historically, did the tribes ever fry dough? No. It's actually rooted in the Commodity Food Program. So people doing the best they can with their commodities. On the right, you can see the elder with her commodity shortening and her commodity flour making fry bread. And this is what people grow up with. It's what I grew up with. It's been acculturated. It's now the norm. We consider fry bread a traditional foods. Anytime I go back home for a ceremony or for a feast, there's an expectation that there will be fry bread. Why? Because it's traditional. And I try to tell my people, no, it's not traditional American Indian food. If you want to call it traditional, it's traditional USDA food. But it's poison. And it's been acculturated. So there are reasons for significant health disparities. I'm sure most of you are probably familiar with the Adverse Childhood Experiences Study, the ACE study. And that study originally was done in California in the late 1990s. And they found that the more adverse experiences that children have, the worse their health status is as adults. And adverse childhood experiences lead to neurological development impairment, social and cognitive impairment, difficulty with behavior and success in schools, higher rates of dropout, adoption of high-risk health behaviors, early onset of disease, and early death. And when I think about the list of American Indian health disparities, it is basically a list of the outcomes of adverse childhood experiences. There's something about unresolved trauma that's having a widespread impact on things like obesity, diabetes, depression, suicide, STDs, heart disease, cancer, even smoking, alcohol use, drug use, and other outcomes like lower graduation rates, worse academic achievement, and higher rates of poverty. We have not adequately assessed this, and it's right in front of us. I think this is going to be the future of our understanding of disparities, is to get a better understanding of unresolved trauma. So if you make it through age 18, does the toxic stress end? No. Living in impoverished communities results in a lot of stressful circumstances. We have a lot of toxic stress in our populations. If you're living in a community that has high rates of addiction, that is stressful. Living in poverty is stressful. And then have we resolved racism in this country? Not even close. And unfortunately in the Dakotas, the racism really is directed at American Indians. There's a lot of overt, unashamed racism going on in the Dakotas. And living under that type of circumstance in which you feel marginalized and discriminated against on a daily basis, that is stressful. And it's causing high rates of stress hormones. Lots of cortisol, lots of epinephrine, things that are not good for us if we have diabetes and high blood pressure. So we have to recognize that the toxic stress is having an impact on health disparities. The other challenge is children who were abused eventually become parents. And what have they learned about parenting? What is the norm? So there are things that we need to do upstream. And there's some very good evidence for home visiting programs and parenting skills programs that are working effectively in other populations. We need to test those types of programs in American Indian populations. When I show these numbers, people are generally shocked. Average age at death in North Dakota, 77.4 years for the white population, 56.6 years for American Indians. Average age of death, 56.6. So I'm 51. I hope I've got a lot more than 5 years ahead of me, right? This is third world health conditions. And I tell my colleagues who work in academic public health, you don't have to cross an ocean to find third world health conditions. It's right here. It's in our reservation communities, it's in many of our inner cities and other impoverished populations. Terribly high rates of early death and health disparities. Nationally, we see terrible trends in preventable illnesses like diabetes-related deaths, alcohol-related deaths, unintentional injuries, and suicide-related deaths. One of the things I always like to point out is that in every data set I've seen, for American Indians, there is a higher percentage of binge drinking and dangerous intake of alcohol. But we also have the highest percentage of abstainers. So we could look at the same data set and say American Indians have a problem with alcohol, or we could say American Indians are the most sober population in the country. Because it's true. We actually have more people who completely abstain. So in the general population, you might have a few abstainers, lots of social drinkers, and a few binge drinkers. For American Indians, it's kind of inverse. We have a lot more abstainers, less social drinkers, and unfortunately, we do have higher rates of binge drinking, unfortunately. Our suicide rates are just a crisis. The rates of death from suicide are more than double for American Indians in the Dakotas. And that is unresolved trauma. That is an outcome of unresolved trauma. And the amount of human suffering that's embedded in that is almost indescribable. And one of our big challenges is that we see higher rates of suicide in young people. We see a spike in the teenage years and early adulthood, then it tapers off. So not only are more people killing themselves, they're doing it at a younger age. So the years of potential life lost is just tremendous. This is screaming for attention, but it's not getting attention. It's screaming for intervention, but we're not doing enough to address it. So I was a co-principal investigator in what was called the South Dakota Health Survey, which was funded by the Helmsley Charitable Trust. So thank you, Helmsley Charitable Trust, for funding this. But the South Dakota Health Survey, we did oversample tribal populations, and we included a lot of information on this survey, including basic information, age, sex, and racial and ethnic connectivity, self-reported health status, and we used a lot of validated survey instruments, including things from BRFIS, the Behavioral Risk Factor Survey. We also screened for mental health conditions, so it wasn't self-report, but we used things like PHQ-2 for depression, the GAD-2 for generalized anxiety disorder, Audit C for alcohol use disorder, and we included the Adverse Childhood Experiences questionnaire in this particular study. And this was completed in 2015. And again, this is for screening for mental health conditions, not self-report. And each set of bars on the far left is statewide, and on the far right is the reservation communities in the lighter blue. And you can see for depression, anxiety, and post-traumatic stress, the reservation-based population had significantly higher rates of depression, anxiety, and PTSD. For the adverse childhood experiences scores, so there's 10 categories of adverse childhood experiences according to the original study. So an individual can have a score between 0 and 10. If you look at a score of 0, for the non-American Indian population in South Dakota, it was about 50% had no adverse childhood experiences. Only about 17% had no adverse experiences for American Indians. We had a few people who were American Indian who had ACE scores of 10, meaning they had endured every one of the adverse childhood experiences, and statistically significantly higher rates of ACEs. If you look at each of those 10 types of adverse childhood experiences, there's abuse, emotional abuse, physical abuse, sexual abuse. For neglect, there's emotional neglect and physical neglect. For household dysfunction, it includes mother treated violently, household substance abuse, household mental illness, parental separation or divorce, and incarcerated household member. For each one of those domains, American Indians had statistically significantly higher exposure to that type of challenge. Again, screaming for intervention, screaming for attention. Something needs to be done about this. And we're doing our best, but even getting people who determine levels of funding for NIH, CDC, SAMHSA, it's hard to do when there's so few of us as American Indians. We need partners in advocacy. We need access to people who can share this information effectively, who can get the word out that there's this crisis occurring right here in the heartland of the United States. So we have significant challenges: ongoing poverty, trauma, political issues at the federal level, the state level, even at the tribal level, inattention and neglect of the issues, racism, and unfortunately continued inequity. And we see outcomes of health disparities, educational inequity, intergenerational poverty, suffering, and death. So we have difficult circumstances ahead of us, and we really need to address equity in a more comprehensive way. We need to understand the need to integrate public health, medical care, and behavioral health care in a more comprehensive manner. Some of you probably have seen this image before, looking at the difference between equality and equity. And equality, on the left here, you can think of those boxes as being a package of services, maybe a Medicaid plan, right? Everyone gets the same package of services independent of your needs. That's our approach, actually, in health policy, looking at the one-size-fits-all approach to healthcare, right? Well, in this example, the guy on the left didn't need it. It's serving the one in the middle well, but the guy on the right is still underserved. So the difference between equality and equity, equality would be like giving everyone a pair of shoes. Equity is giving everyone a pair of shoes that fit, right? We're not very good at that in healthcare. The one-size-fits-all approach has been what we've always done. But is it possible that, for example, in a recovery program for addiction for American Indians, incorporating traditional cultural perspectives might be of value? And we've actually proven that. We see less recidivism when there's culturally relevant services provided. But that won't be paid for under Medicaid because of equality. Because if we offer that to one population, we have to offer it to everyone. And if we can't offer it to everyone, we offer it to no one. That's equality, right? But it's not equity. We have to be smarter about this. So I've shown this picture now for a number of years, and someone sent me a picture that I think is even better. And the question is, why is the fence there in the first place? So maybe it is about equality in some cases, it's about equity in some cases, and maybe the bigger picture is to break down those systemic barriers, right? What are the systemic barriers that limit access to healthy food? Systemic barriers that limit access to good education, good economic development programs. And perhaps our vision of healthcare needs to broaden and recognize that the social determinants of health really are ubiquitous across our experiences. So I do want to leave plenty of time for questions and discussion, but I did want to just offer a few thoughts. You know, what are some solutions we could consider? We do need to improve our understanding of American Indian health. Our issues are largely ignored, largely an afterthought. Some of our worst disparities are not even known, right? And there's so much attention paid to things like international health. And again, I believe in a world community, and I think it's important to do that. But it's also important to recognize that we have people living right here in the US whose needs are not being met. We need, I think, a better understanding of historical trauma, certainly understanding of the impact of things like boarding schools and things that are unique to American Indian populations that are not well understood. That should be a part of our history books. It should be a part of what children learn is the truth of history. Because again, if we want to get to equity, we have to walk through truth, even when it's unpleasant. For adverse childhood experiences, we do need to have the studies to document the disparities and certainly get baseline numbers. But even more important, we need to start doing something about it. So there are programs, like I mentioned, that are very promising. Things that include home visitation, community health workers, parenting skills. And they're showing good outcomes, but they're all funded by grants, right? So what happens when that grant ends? So the whole program ends, right? So maybe we need to also think about health policy. If we have programs that are working, that are actually going to save lives and decrease suffering, maybe it should be billable under Medicaid, right? Maybe we need to all gather around those types of ideas and recognize that there are things that we could do with information and ideas and policy solutions that are not yet at the level they need to be to make a bigger impact. Maybe that's something we could do together. There may be some of you interested in this. Certainly advocacy as well. We don't have enough resources in Indian Health Service. We don't have enough programming, but we also have to be included in data sets. And that's another challenge is quite often you'll see a health data set probably reported even in some of your settings where you'll have Caucasian, African American, and Hispanic data. No American Indian data, right? We are not included in every data set. Is that a problem? Should it be addressed? Who better to address it, right? So these are some potential solutions. And other things that are going on now, looking at systemic barriers, we are broadening our research focus in North Dakota to recognize that there are systemic issues and other social determinants of health that have a big impact on outcomes. And just as of this week, starting next month, I'll be working in a different capacity, actually as an Associate Dean of Diversity, Equity, and Inclusion at the medical school in North Dakota. And our whole area of focus is going to be on increasing diversity in the workforce, but also a focus on equity to ensure that we are included as these things move forward. I always like to end with this saying from the Blackfeet tribe. A child is sacred, and when that child comes into the home, the family must welcome it. And if the child is happy and feels the want, he will come into this world very, very strong. And not to know this is to know nothing. And not to know this is to know nothing. When I think about our beautiful traditional cultural ways, it didn't include adverse childhood experiences. It wasn't about abuse. And in truth, when we look at this from a historical perspective, our people learned abuse in boarding schools. There's never been reconciliation around that. There's never been adequate healing around that. Other countries have done it. You should look at what they've done in Australia around reconciliation regarding the residential schools for Aboriginal Australians. Even in Canada, there's an entire truth and reconciliation project addressing First Nations, the Aboriginal people in Canada. Have we done that here? No. It's been ignored. And again, it can't keep being ignored. We all have a role to increase awareness. We all have a role to improve outcomes for the most vulnerable, particularly our children. But I have selfish reasons. I have 4 children of my own. It's a picture of 2 of them. My daughter on the left, one of my boys on the right. And my vision for the future is in the time of their children, what if we did not have these inequities? What if we didn't have to have this discussion about bad outcomes in the time of my future grandchildren? That's a vision I want to pursue. That's a vision I hope we can share together. Aho, pilame ayolo, mitakuye oyasi. Thank you all very much.
Thank you, Dr. Warne, for that wonderful, enlightening talk. We're going to take questions now if you want to move toward the microphones. I don't know about you all, but I know when Dr. Warne shared some of this information with me earlier today, I was shocked by some of the stats that he shared. So I know some of you might be feeling the same way. It looks like we got lots of questions for you.
Very good. Yeah, please.
Is that mic on? Can you guys hear her? It doesn't appear to be.
Yeah, there it is, I think.
Yeah.
There we go. There we go. That's right.
So I'm Caddy Graham, a freelancer mainly based in New York. I am remembering almost 35 years ago the Washington Post Rosebud series, which talked about a lot of these issues. So my question is one, how much of the lack of movement, as you're documenting, do you think is a lack of will? How much of it do you think is straight ignorance? And 2, if you would spotlight particularly among tribal clinicians, good work being done that would model the kinds of things you hope for.
Excellent questions. And I would say, for the first part of your question, I'd say all of the above, right? That there's challenges with just people not being aware of the issues, and then also the will to do something about it. And I've heard just horrible statements in various settings, including from state legislators in South Dakota who are almost proud of their racism toward American Indians. And I don't see a lot of good rhetoric coming out of Washington, D.C. right now either. So I would say there's a huge challenge with we're balancing ignorance and people being unaware, but we also have overt racism that we have to contend with as well. In terms of best or promising practices, there are a lot of them. One of our challenges historically is that we haven't done a good job of formally evaluating programs and publishing them, things that are working in Indian country, because now we have to focus on evidence-based practices. I'm sure you're all familiar with that term. So my first question is, whose evidence is it, right? If it works effectively in Boston or Atlanta, does that mean it's going to work in Pine Ridge? Not necessarily. So there's a whole need to not only identify and highlight best and promising practices in Indian country, we need to publish them and make them a part of our evidence-based practices inventory. So thank you for that question. Yeah.
Hi, I'm Jim Mulder, a reporter from Syracuse, New York. Thanks for your presentation. I was just wondering if there's any data that shows whether there's a difference in the rate of health disparities among American Indians who live or grew up on reservations versus American Indians who live and or grew up off reservations.
Yeah, it's a very good question and sometimes difficult to track. So for example, in my own experience, I lived in both. So which one am I? You know what I mean? Because it's kind of a dichotomy. Is it you're either this one or that one? Well, if I live both in reservation communities and in a city, which most of us do actually, it's kind of a hard thing to quantify. But we are seeing is that the population of American Indians who live in urban settings tend to have very similar patterns of disparity as those who live in reservation communities. But each community is different, so it's hard to aggregate nationally and really get a good picture, because I'd say in some states, the American Indians living in reservations probably have much worse outcomes than those who are living in cities, but that's not true in every state. So when you aggregate all of the data nationally, you lose a lot of the nuance of some of those differences. But the data that I have seen show that American Indians currently living in cities also have significant disparities.
Thank you.
Thanks so much for that excellent talk. My name is Karen Landman. I'm a freelance journalist. I'm curious how much of a role members of the U.S. Public Health Service have in providing and shaping healthcare to American Indians on reservations and in general, and if you think that their participation in this and their role in this is overall a good thing or a bad thing, and why? Thanks.
Excellent question. So Indian Health Service is a part of the Public Health Service, which is kind of ironic because we do very little public health in Indian Health Service. You know, the budget is so small, we can do medical care, but very little in the way of prevention. So there's basically two ways you can work for the Indian Health Service. One is as a civil servant, so more of a civilian job. The other is as a commissioned corps officer. So the commissioned corps is where we have our U.S. Public Health Service professionals that can then be deployed when there's a crisis, like a hurricane or other type of natural disaster. So what happens is a lot of the Public Health Service officers are working in IHS, and it's good that they are there, but then when they need to be deployed, IHS loses a lot of its workforce. So we create one crisis while we're trying to solve another. So I wouldn't say it's good or bad. I think there's wonderful things about it, and there's challenges within it. One of the big challenges is also related to cultural competence. So if you've seen U.S. Public Health Service officers, whether they're doctors or dentists or pharmacists, they're uniformed. So they dress like soldiers, right? You know, Casual Friday, they actually wear combat fatigues. Dentists, pharmacists. So think about that. Think about the history of warfare between the tribal nations and the U.S. government. And what type of message are we sending when we say your doctor's going to dress like a soldier to take care of you? And oh yeah, and on Friday he's going to wear combat fatigues. So talk about structure, institutionalized cultural incompetence. That's a big part of it. But if the option is to have no providers, we take that. But thank you for bringing that up. Yeah.
Hi, Dr. Warne. Thanks so much for your talk. So I really appreciated the topics you brought up about trauma, and that's something I would love to report on. I do already, but I'm in Texas, and from what I know of Native American history there's very few tribes left there. So how do you feel about people dropping in, parachuting in to report on a story when they're not from the area? Because that would be really the only way I could really report on those kind of things where I live.
Yeah, and that's an excellent point, and it's something I put a lot of thought into. And in truth, what we need is even for researchers and for whether it's journalists or any other profession that wants to engage tribes, we need to link you to the tribal champions for these issues, because they're everywhere. People want to increase awareness. So it'd be very difficult to just show up, you know what I mean? So I think one of the things that's incumbent on us as tribal health advocates is to identify a whole cadre of community champions who would be willing to work with you. Because if you had a well-respected community leader who was a champion within the community as your partner in trying to gain access to the community, that would go a long way to increasing access. But it's a very good observation. You can't just show up and expect that there will be a lot of trust automatically. We used to joke, when we'd have responses to different types of crises. I'm from the government and I'm here to help. It's not necessarily well received in tribal populations. But I would love to be a part of helping any and all of you if that's something you wanted to do. I know a lot of advocates across the country who would be more than happy to share their stories. That's my email address right there. Feel free to reach me. Thank you.
Hi, Andrew Holtz, independent journalist in Portland, Oregon. Was wondering if you have tips for how reporters whose organizations, outlets, audiences are mostly not American Indians, ways to convey this information that's going to engage those readers, because there's unending competition for attention, and editors and audiences, they say, oh, why should I care about that? I mean, obviously it's pretty devastating history, but you can't force somebody to read it. So are there tips and ways of presenting this that you have found grabs the attention of the vast majority of people in the country?
Yeah, and it's humanizing it. It can't just be a story about data. It's got to be a story about people. And I think having an actual example, a story of an individual who's endured some of these challenges to help tell that story is much more powerful than just presenting the data. And I'm sure you do that a lot in terms of your own stories and identifying people who would be willing to share their story as part of this. And I think that's much more effective than just presenting the data. And when I think about, we have investment in human interest stories, someone's having a challenge, it gets on the news, and suddenly there's a lot of donations to a particular cause because it was humanized. But that same type of circumstance could be happening with dozens of other people. But if we can humanize it and get it in front of people, I think we have a chance. But we're not going to reach everyone. I think we do have to be honest about that. There is, unfortunately, a degree of apathy around these issues. We're not going to change everyone. But I would assume that there's a lot of people that if they were aware, they would want to do something about it if they could. Thank you.
Hi, I'm D.P. Brower. I'm an independent journalist from Oakland, California. My question is looking at things like alcoholism rates, suicide rates, rates of abuse, things like that. Have you noticed any differences, or has anyone even studied differences between different populations of Native Americans? Different regions, perhaps? Is there, a bright spot anywhere where perhaps the culture remains stronger and there's lower rates of abuse or alcoholism? And I'm also thinking particularly of Native Hawaiians.
Yeah. No, that's a great question, a very good point. We do see a lot of regional differences in American Indian health and patterns of disparities. So there is a report called Regional Differences in Indian Health that's published by IHS, but they're always about a decade behind in their data, unfortunately. But just a couple of years ago, maybe 4 years ago now, American Journal of Public Health published a supplement on American Indian and Alaska Native mortality. And it went through all kinds of different types of disease processes, and it showed the regional differences. And unfortunately, in the northern plains, we tend to see the worst outcomes. In other parts of the country, actually the Portland area, we tend to see some better outcomes in many cases. And then there are also pockets of populations that are doing things very effectively, even if the rest of the region is not. So it depends how granular we can get with the data. But yes, there are examples of things that are working well, even in the regions that have the worst disparities. But we see tremendous variation across regions. But I'd recommend looking at that American Journal of Public Health, American Indian Alaska Native Mortality Supplement. I'm such a nerd. I mean, this is the type of stuff I read. So I think
Just
that'd
a
be
quick
helpful.
follow-up. Is anyone trying to collect all of that and try to implement, things that seem to be working in some populations across others?
In a limited way, that's one of the things we're doing is compiling an inventory of best practices in American Indian health. And there have been a couple of publications looking at that. The challenge has been the level of scrutiny required to be considered an evidence-based practice is pretty high. So if you look at SAMHSA or CDC, to actually be considered an evidence-based practice, it requires a lot of evaluation. And we just haven't had the resources to do that, to meet those standards. And the reason that's important is that quite often a grant opportunity will be put forth, and they'll say, here's your list of evidence-based practices. You have to pick one to implement in your community, whether or not it's ever been tested in a tribal community. So we need to put more resources and effort into building the evidence base of effective Indian health programs. So very good point.
Hey there, thanks for the talk. I'm Matt from Omaha, Nebraska, independent journalist. And out in my neck of the woods, IHS has started to grab a little bit of attention with the Winnebago tribe. They are right now in the process of moving forward with self-determination, taking control of the IHS hospital out there. And from my outsider's perspective, it would seem that that would be the very positive development because the people that would be running it would be people that are locally involved. But I would love to hear from you if, in your observation or in your research, if you've seen that that's the case, that when tribes assume control of the hospitals, how do outcomes go? How are patients faring?
Yeah, that's an excellent point. Some of you might be familiar with the self-determination law. It's Public Law 93-638, was passed in 1975, and it allows tribes to take over the management of healthcare programs from clinics, hospitals, and any type of program, function, or service, so they can actually manage it locally. That's why we have a mixture of IHS facilities and programs and tribally operated facilities and programs, because of Public Law 93-638. So actually in Indian country, the term 638 has actually become a verb. We're going to 638 the clinic, or we 638'd the hospital, basically means that they've taken it over. And what I've seen, of course, you can think of it as kind of two normal curves of quality, and IHS, lower quality of care, but some examples that work very well. But for the tribal programs, I see them doing much greater quality. Now, there are examples on the tail where they're not working as well, and those who are anti-self-determination like to point those out. But the truth is, the vast majority of 638'd sites are operating much more efficiently and effectively than the IHS-managed system. So I encourage tribes to move in that direction. Same thing's happening in the Dakotas. Now, what's interesting, just as a side note, Omaha is a tribe, the Omaha, which is closely related to the Oyate, which is Lakota, Dakota, and Nakota. And, I had mentioned that the colonization came from the east. The Lakotas were further west, Dakotas further east, and the Nakotas and Omahas further south. So that's why it's North Dakota, because that's who they encountered first. If colonization was from the other direction, it'd be from North Lakota.